Welcome to The Explainer. Today, we're stepping right into the high-stakes, split-second world of the trauma ICU. If you're looking to master the absolute cutting edge of emergency trauma care, you are exactly in the right place. We're breaking down the brand new ATLS 11th edition updates for 2025, and let me tell you, there's a massive paradigm shift happening right now that is literally changing how we save lives.
Okay, let's dive into this. Just like a highly organized trauma team, we need a clear roadmap. We're going to cover the golden hour, the XABCDE paradigm shift, breathing and the deadly 6 chest injuries, circulation and hemorrhagic shock, disability and the lethal triad, and finally, modern damage control resuscitation. Let's get started.
Section 1. The golden hour and simultaneous action.
Picture this. The trauma bay doors fly open. A patient arrives. This is a fast-paced team sport, right? And actions in that first golden hour dictate survival. Which brings us to an incredibly urgent question. What is the most common cause of preventable trauma death? Think about it for a second. Got it? It's uncontrolled hemorrhage. People are simply bleeding to death before we can even begin to fix anything else.
Moving to Section 2, the XABCDE paradigm shift. Stop hemorrhage first.
So medical science has rapidly evolved to address that #1 killer. For decades, we were taught the sequential ABC approach. Airway first, always. But here's the catch. That sequential method was just way too slow if a patient was actively bleeding out. The modern approach is a simultaneous team effort with a brand new absolute top priority, XABCDE. The X stands for stopping massive exsanguinating hemorrhage before you do absolutely anything else. Because think about it, if a patient has a severed femoral artery, they'll die in minutes, even if you manage their airway perfectly.
And this brilliantly illustrates the new primary survey algorithm right from the ATLS 11th edition. Notice right up top that red box. The X is exsanguination control. If there's visible, massive external bleeding, you stop it right then and there. Only after that's handled do you move down the algorithm to A for airway, B for breathing, and the rest of the whole shebang. It is a fundamental rewiring of our emergency priorities.
So how exactly do we stop it? The new guidelines highlight 3 critical, fast-action tools to shut down that exsanguinating hemorrhage instantly. First up, the tourniquet for limb bleeding. You apply it tight, 5 to 8 centimeters above the wound, and you leave it on until surgery. Second, wound packing with hemostatic gauze and continuous direct pressure for non-limb wounds. And third, the pelvic binder for those open-book pelvic fractures. You apply it precisely at the greater trochanters to physically reduce pelvic volume and tamponade that venous bleeding. Basically, these tools buy you the critical minutes needed to keep the patient alive for the rest of the survey.
Section 3. Breathing and the deadly 6. Find and fix fast.
All right, once massive bleeding is controlled, we secure the airway and assess breathing. Why? Because a blocked airway kills in minutes. We absolutely have to ensure air is moving freely. But wait, here's a major clinical trap you must avoid. You need to check for a pneumothorax before intubating a patient, assuming you have the time. Why does that matter? Well, if a patient has a simple pneumothorax, meaning air trapped in the pleural space, and you put them on positive pressure ventilation, you can instantly turn that simple pneumothorax into a deadly tension pneumothorax. You're essentially pumping high-pressure air into a trapped space, rapidly collapsing the lung and crushing the heart. Definitely not what you want.
Now, what's really interesting about these immediate threats is how they're categorized. These are the deadly 6 chest injuries that absolutely must be diagnosed and treated during that primary survey. Up top, we have tension pneumothorax, cardiac tamponade, and massive hemothorax. These guys will completely crash your patient's circulation. Below those, open pneumothorax, flail chest, and tracheobronchial disruption, which severely impair ventilation. You don't wait around for a chest x-ray if you suspect a tension pneumothorax, for example. You act immediately with a finger thoracoscopy.
Section 4. Circulation and hemorrhagic shock. Where is the blood?
In the context of trauma, any sign of shock must be considered hemorrhagic shock until proven otherwise. Period. Your patient is losing blood, and your primary job is to find out exactly where it's going. So we look to the 5 hidden sources of blood loss, often called the torso rule. Blood is hiding in the chest, the abdomen, the pelvis, the femurs, or pouring from external wounds. It's actually kind of terrifying to realize that a single femur fracture can hide up to 1.5 liters of blood just in the thigh compartment. Or the abdomen. It can silently pull liters with 0 external signs. You literally have to actively hunt for the blood loss.
Which brings us to understanding the stages of shock.
Notice the vital sign trends in the 4 classes of hemorrhagic shock. It tracks blood loss as it increases from less than 15% in Class I all the way to over 40% in Class 4. As the bleeding worsens, you see the heart rate steadily climb into tachycardia, the blood pressure eventually plummets, and mental status, it degrades from anxious to completely unresponsive. It's really a clear descending staircase of physiologic collapse.
But please do not wait for the blood pressure to drop. A narrowing pulse pressure, which is the gap between the systolic and diastolic numbers getting smaller, is often the very first sign of hemorrhage. It happens before the overall blood pressure actually takes a hit. So if a patient is sitting at 110/90, they're already bleeding significantly. Gotta be super vigilant and catch these early warning signs.
So, the crucial point is how we respond to that blood loss, and the new 2025 ATLS guidelines have completely changed the game here. The target systolic blood pressure is now just 80 to 90 millimeters of mercury. This is called permissive hypotension. Back in the day, we aggressively pushed fluids to get blood pressure back up to a normal 120. But we learned that this actually blasts away fresh blood clots and dilutes the patient's remaining clotting factors, which just makes the bleeding worse. Now, we keep the pressure lower to protect those fragile clots until the hemorrhage is surgically controlled.
Section 5. Disability and Exposure. Neurological Assessment.
This covers the D and E of our primary survey, where we take full control of the patient's physical environment. For disability, we're doing a quick Glasgow Coma Scale check and testing pupil reactivity. But here's a massive update for 2025. The automatic use of full rigid spinal boards and collars on every single trauma patient, it's gone. Spine motion restriction is now based entirely on clinical assessment and risk factors, no more blanket rule. As for exposure, the rule stays simple. Completely remove all clothing to find hidden injuries. You absolutely must log roll the patient to check their back, because you can't treat an injury you can't see, right?
But the second you remove those clothes, you must immediately cover and warm the patient. Why? To prevent the lethal triad. This is a fatal, self-worsening physiological loop consisting of hypothermia, acidosis, and coagulopathy. Hypothermia impairs clotting enzymes, which leads to worse bleeding, or coagulopathy. That extra bleeding causes poor perfusion, leading to acidosis, which further ruins clotting. It's a vicious cycle that will quickly kill your patient if you don't actively step in and break it by warming them up and using warm IV fluids.
Section 6. Damage Control and Resuscitation Updates.
Modern trauma care isn't about perfectly fixing every single broken bone right away. It's about stopping the bleeding surgically and fixing the rest later in the ICU. And a massive part of this modern approach is the 1-1-1 ratio. We used to pump trauma patients full of 2 liters of saline right off the bat. No more. The new standard is strictly limiting crystalloids because they just dilute the blood and worsen that lethal triad we just talked about, and instead replacing what was actually lost with early red blood cells, fresh frozen plasma, and platelets in equal 1:1:1 parts. Essentially, we're replacing whole blood with the components of whole blood.
Let's step back and see how this builds into the broader picture of modern resuscitation. There's a stark difference in the two approaches here. The old way relied super heavily on large volume crystalloids, which we now definitively know cause dilutional coagulopathy and just worsen the bleeding. The new resuscitation standard seamlessly combines everything we've been discussing, giving TXA early, utilizing that 1-1-1 blood product ratio, and maintaining that permissive hypotension.
I do want to briefly highlight the role of TXA, or tranexamic acid. It's an amazing clot stabilizer that stops the body from breaking down its own vital clots. But time is absolutely critical here. You give 1 gram IV within 3 hours of injury, though ideally we're talking within the very first hour. If you give it after 3 hours, evidence shows it can actually do way more harm than good. Precision and speed matter immensely here.
Well, we've covered a tremendous amount of ground today, from permissive hypotension to the lethal triad. But I want to leave you with this final critical thought. If you were facing the golden hour right now, staring down the chaos of a trauma bay, would you remember to look for the X before the A? Take a moment to really memorize this paradigm shift. Stop the bleeding first. It's just a simple change in the alphabet, but it's one that will absolutely save countless lives. Keep learning, stay focused, and I'll catch you on the next explainer.